So let's review secondary endocrine organs. A lot of hormones that are produced by organs like heart, lungs, liver, kidney. We're going to review when we get to those organs. So I'm not going to talk in details, okay? We're going to start with the heart. And there's a hormone called atrial natriuretic peptide. Also known as ANP. Now, natriuretic. When you see uretic, it means that something gets released in the urine. Are we clear? Now, natri is actually, I think it's Greek, for a chemical element, which known in English as sodium. So, atrial natriuretic peptide is the hormone that increases the release of sodium in the urine. Does that make sense? And you look like and you feel like a lovely bunch, really, engaged bunch. So here's what we're going to do. I'm going to write the effect first, okay? So the effect of this hormone, check this out. Increased sodium excretion in the urine. Are you with me? Do you remember what follows sodium? Water. So increased sodium excretion means increased water excretion, right? Basically, you pee more. Okay, when you pee more, what happens to the blood volume? What happens to blood pressure? So what's the stimulus?
High blood pressure.
In case of high blood pressure, the mechanoreceptors in your atrium respond to that high blood pressure and release ANP. ANP increases sodium excretion. Isn't that elegant? Does that make sense? That's really cool. That's your heart. Now, let's get to the stomach and the intestine. We're going to start with the stomach. Okay, so two hormones. When you have empty stomach, how do you feel? Here's why. Your stomach produces the hormone called ghrelin. I think it's GH, I'm not sure about spelling. So ghrelin acts on the hypothalamus and you feel hungry. Does that make sense? I sometimes joke that this is one of two hormones which we can ignore. Because technically, it's your voluntary decision to eat something, right? So you can technically say, I'm not eating. I'm hungry, but I'm not eating, right? You're still going to feel hungry. It's not, ghrelin doesn't make you eat. You're not going to start shoving stuff in your face. Are we clear? Second hormone, gastrin. So, I'm prepping you for the next chapter for digestive system. So, remember how we talked about negative feedback? Now negative feedback eliminates the original stimulus. So let me ask you a very simple question. What is the original stimulus in the digestive system? What is the change that happens in the digestive system? The answer is a four-letter word, starts with F. Food. That makes sense? So, every time we talk about digestive, you basically have to think, are we talking about food or are we talking about lack of food? Okay? So in this case, food in the stomach results in the release of gastrin, which increases acid production and overall digestion. digestive activities. Does it make sense to you? And it actually explains, if you think about it, food, gastrin, increased digestion, food gets digested. Clear? You good? Okay. Intestines. Properly speaking, technically small intestine, but we're going to throw intestines like general, okay? So 4 hormones. A pair of secretin and cholecystokinin. Secretin. What is the stimulus? If it's intestines, if it's digestive. Food. Yeah, so again, food ends up in your intestines. That stimulates the release of secretin, which acts on the pancreas to release pancreatic juice. Okay, and cholecystokinin acts mostly on the gallbladder, release of bile. Now, to clear my conscience, here, cholecystokinin also has an effect on. So basically, you need both secretin and cholecystokinin to stimulate pancreas. That makes sense? Secretin stimulates liver a little bit. It's not important right now. We're going to talk about it, okay? But cholecystokinin stimulates your gallbladder. So basically, when you eat something and food ends up in your intestines, in the duodenum, in the small intestine, your gallbladder will contract in response to cholecystokinin and release bile in your duodenum. Does that make sense? This is why, and the main stimulus, just FYI, the main stimulus, we say food, the main stimulus for cholecystokinin is fat. It's not for this exam, no, but next one we're going to talk about it. But here's the thing. You're probably familiar with the condition known as cholecystitis, inflammation of a gallbladder, gallstones. So when people have gallstones, they have pain in the gallbladder when they eat. Because when they eat something kind of fatty, gallbladder starts to contract. You follow me? Trying to push bile through the stones block the path, and it gets painful. Make sense? A couple more. So GIP and GLP. So GIP is gastric inhibitory peptide or protein. GLP, glucagon-like protein or peptide. I never remember peptide or protein. It doesn't really matter. We are not talking about those hormones pretty much at all. They are produced by your intestine in response to food, and they have insulin-like properties. So they essentially increase the uptake of glucose, they increase the uptake of amino acids from the blood. Does that make sense? Any questions so far? Okay, this, stomach, intestines. So what we've got inside? We've got liver and kidney, okay. So, liver. Let's do with liver. Oh, crap. Okay, I will have to actually put it in a huge perspective. So we're going to do kind of a map, you know. So one of the hormones of the liver is thrombopoietin. Okay? So thrombopoietin, low platelets, increased thrombopoietin, high platelets. That makes sense. When you run low on platelets, your thrombopoietin levels increase. Now, it's actually a pretty cool story here. Check this out. Thrombopoietin is produced by the liver, but the hormone is physically bound to platelets. Now, put your pens down and just listen to me. So it's bound to platelets. My left hand is a platelet. My fist is the hormone. When it's bound to platelets, it doesn't work. And for some reason, platelets, disappear, become low. You suddenly have a lot of free thrombopoietin. Does that make sense? It stimulates your bone marrow to make new platelets and your spleen to release new platelets. New platelets appear, bind thrombopoietin, and the levels of the free one go low until platelets go down again. Does that make sense? I think it's genius. Another hormone from the liver is angiotensin, but it's a part of a bigger network, and we're going to talk about it. So liver produces a hormone called Angiotensinogen. Right? Now, if you look at the name, it's basically medical terminology. Check this out. Angio refers to blood vessels. Tensino refers to tension. Okay? Pressure, basically. So angiotensinogen is the precursor of a hormone known as angiotensin. Okay? Now, the conversion of angiotensinogen into angiotensin happens in the lungs. Okay? And angiotensin, what it does, it stimulates release of aldosterone. I know it's been just a week, but anyone remembers what aldosterone does? One of the hormones from the adrenal gland. It's a mineralocorticoid. It increases the retention of an ion. If somebody says iron, 90 out of 100%, it's going to be sodium. So we can just, if you don't know, you can just throw sodium, and it's going to be sodium. So increased aldosterone means increased sodium retention. Increased sodium retention, how does it change your water retention? Increases, because water follows sodium. Does that make sense? Remember that phrase, water follows sodium. If you keep sodium in, you keep water in. If you keep water in, what happens to your blood volume? Increases. And if your blood volume increases, what happens to your blood pressure? And if your blood pressure increases, what was the original stimulus? Huh? Decreased blood pressure, right? Yeah, decreased, because sometimes I can't hear. Now, no, probably because of that thing, the plastic thing. But here's the thing, here's another thing. So, decreased blood pressure does not stimulate liver directly. Check this out. Decreased blood pressure acts on the cells in the kidney. Does that make sense? Which releases a hormone called renin. Right? And renin and renin stimulates the release of angiotensinogen from the liver. Does that make sense? Now, kidneys, we got kidney in the picture. So kidneys produce renin as a hormone. They also produce a hormone called erythropoietin. Right? Now, erythro refers to red blood cells. So, low red blood cells, erythropoietin, elevated levels of red blood cells. So when you're bleeding, when you have anemia, that stimulates the release of erythropoietin. Does that make sense to you? Good? So liver makes some other hormones, but I want you to know, for now, basically these two: Angiotensinogen and thrombopoietin. Okay, we good? Julia, question?
Oh, no, just looking.
Okay, that's fine. We're good?
Okay. Actually, yeah, I do have a question. At the top, is that a B or is it an R or a B first?
This one, R, red blood cells.
And same for the last one?
Yeah, so low red blood cells, when you run low on red blood cells, and this is why endurance athletes illegally use EPO, erythropoietin, as the performance enhancement drug. You take it, you get more red blood cells, you get more oxygen carrying capacity in the blood. You also increase your risk of stroke, but you know. That makes sense? Clear? Okay, awesome. Liver, I'm missing something. I think what I'm missing is skin. And there's one primary organ that I forgot to mention. I will throw it in here. It's fine. So for skin, the only hormone is vitamin D. Okay, cholesterol. So now we drew the skin today earlier with the parathyroid hormone. So basically, when you are exposed to UV light, your skin produces vitamin D, okay? And vitamin D gets activated in your kidneys by parathyroid hormone. Remember that? Remember, we're talking about this? Yeah, so vitamin D gets activated by PTH, becomes active, increases absorption of calcium in the intestines. Now, that brings us to a very important question. Should we take calcium? Well, we actually should, because there's a how much sunlight should you get a day to satisfy to make your body produce enough vitamin D for proper calcium absorption. You're going to get out there in the direct sunlight for 15 minutes stark naked, which obviously is not going to happen. I mean, I don't know about your lifestyles. Definitely not going to happen to me. Especially in the state of Ohio, direct sunlight is not a frequent occurrence. And in the winter, it can be a little challenging, you know. So basically, kind of a consensus, we probably should take vitamin D supplements. The current recommendation is, they differ between like American Academy of Pediatrics, American Society for Hematology, kind of around 800 mg per day. Okay? If you take that amount of calcium, that should be sufficient. Make sense? Okay. Two of my favorite hormones. Hormones of the adipose tissue. Basically, fat. So first is Adiponectom. It is a fascinating hormone. It is produced by fat. The stimulus is not particularly clear. Most likely it's food. So I'm not going to be able to give you my regular, schematics like stimulus, hormonal response, stuff like that. That makes sense? I will highlight some of the functions of Adiponecta. So it is anti-inflammatory, strongly anti-inflammatory. We're going to get back to this. And it is also regulates energy balance, like broadly speaking. So what are the interesting features of Adiponecta? So first of all, let's talk about its regulation of energy balance and its association of adiponectin with obesity. Interestingly enough, in people with obesity, adiponectin is decreased. And basically it's a dose-dependent response of sorts. Higher BMI means even lower adiponectin in the blood. Does that make sense? The statement. I'm not saying that it's logically makes sense. It's just an interesting feature. We don't really know the exact mechanisms here. Now, about anti-inflammatory effects, it's even more interesting. So, if you will take mice that suffer from such inflammatory disease as atherosclerosis, you can, like mouse model of atherosclerosis, does that make sense? And you give them adiponectin in some form. The narrowing of blood vessels will not completely disappear, but will be relieved to a large extent. Makes sense, right? We know that for sure. You give diabetic models, there are mice with diabetes, you give them adiponectin, and diabetes related, the insulin sensitivity improves, the glucose tolerance improves, basically the diabetes improves. You give it to mice with models of cardiovascular disease like chronic inflammation of the heart, inflammation gets reduced. So it's a strong anti-inflammatory agent. So far makes sense, right? Well, here's the kicker. And if you look at people, like people with atherosclerosis, diabetes, obesity, they have low adiponectin. But you look at people with primary inflammatory conditions, like rheumatoid arthritis, so basically autoimmune disorders. In those people, chronic autoimmune inflammatory disorders, in those people, surprisingly, adiponectin is through the roof. We don't really understand why. If you look basically at the acquired inflammation, like you eat yourself to this, it's lower. You look at chronic autoimmune condition, it's super high. We don't know. Not the slightest idea. That makes sense? My favorite hormone, though, is leptin. So it's produced by adipose tissue. This is how it works. You eat, okay? You produce leptin. It acts on the hypothalamus, so you feel satiety. You're full. Does that make sense? So, a couple of comments here. Comment number 1. You know this ages-old recommendation to get out of the table a little bit hungry? Like when you eat, you don't eat till you're full, you're just a little hungry. Makes sense. Because it takes time for leptin to completely kick in and give you an idea, yeah, you ate enough. Second, this is the hormone that we definitely ignore. You eat 1 slice of pizza, 2 slices of pizza. Like after 2, you should be done. You eat 3rd and 4th because it's just so damn good, right? And here's what happens. When you eat, when you constantly overeat, your leptin levels are constantly elevated. Are you with me? When your leptin levels are elevated, leptin acts on the receptor. What happens to that receptor? Think about.
It's desensitized.
It's desensitized. People develop leptin resistance. And it is very clearly seen in people with dietary obesity. People who ate themselves into 400 pounds, right? In those people, leptin levels are very high, even when they fasting. Because their receptors just not sensitive enough. Does that make sense?
If you change your ways of eating, can they go back to normal?
Yeah, you can, same as with insulin, lifestyle changes will restore leptin sensitivity as well. Yeah, good question. And it's really interesting to see at people in mice. So in people, there are people who are leptin deficient. I have an illustration in the notes, a boy. The first photograph of like a morbidly obese kid. He was like 4. He weighed more than like 100 pounds or something. Because leptin was not produced and he had no control over eating. He would just, he had not had satiety. Does that make sense? He was placed on basically leptin supplements, like I think it's with IV something, and he lost weight. In mice, it's a model of obesity, which I personally completely despise, because regular lab mouse weighs about 25 grams, the adult animal. More or less, 25 is about right. So I had obesity model based on a fat diet, just high-fat diet. It, by the way, tasted delicious. I tried it. It was like a cookie dough. Great, sweet, phenomenal. Mice gained some weight. The biggest one, I think I had 60 grams. It was a blob, but moved around. Well, think about this. Like, I'm 180 pounds. So, average weight. So a person would be basically twice my size, 360. I've seen more in the United States, especially in the South. So yeah, people move, people walk. Mice that are deficient in leptin, 60 is like a low bar. They go way above 60 grams of body weight. They are literal blobs. It's really hard for them to move because their legs can barely touch the ground. They're so big. Okay? I don't like this model of obesity because it's so unnatural, you know. It's not like they ate themselves into it. So that's about leptin. And it's, you know, for me it's interesting that in obese people it's constantly increased. Do you have a question?
Does gastric bypass affect this? Like if somebody had gastric bypass, does like the shrinkage of the stomach
I know.
affect?
That's a good question. I don't know what to tell you. It probably does to an extent, but I don't know exactly. That's a really good question. I'm going to look it up because it's just, I never asked myself this question. So, very last bit about hormones. There's one gland that we didn't talk about, thymus. All you need to know for thymus. It's a primary, it's not secondary, but I just throw it in here. So thymus. It's a weird gland. It produces thymulin, thymosin, and thymopoietin, 3 hormones that are responsible for T-cell maturation. That's it. That's the whole function. It's a weird gland. It doesn't operate like normal endocrine glands do. Okay, we good? Questions here?
Did you say that skin was also a primary?
No, it's secondary. Everything that we talked about except thymus in this little chapter was a secondary endocrine organ. Okay, any questions? Okay, good.